It's not moving. Yeah, so now the case history, she's 27-year-old lady and married life is 4.5 years. Her BMI is 19.5, which is less. And she also had complaint of irregular menstrual cycle. The menstrual history is irregular, moderate, painless, and around 4 to 5 days. And she used to get her menses every 2 to 3 months. Her first visit to our center was on 30th October 2025, and presenting complaint was primary infertility. So seeking fertility evaluation as well as treatment. The primary diagnosis that I did in this case was thin PMOS and primary infertility. So she belonged to the phenotype lean phenotype PMOS, presenting with irregular cycles, low BMI, requiring nutritional and lifestyle optimization ahead of fertility treatment. So the previous investigations in her included hysterosalpingography, and in the hysterosalpingography, the doctor found that it was left tubal block. Now, the initial medication and treatment by the referring doctor to us, he had given her folic acid. What is most important in cases of PMOS is the pre-treatment optimization. Medications that I prescribed in this case was metformin 500 milligrams, one thrice daily, after food with 1.5 glass water, so that she continues to take this medicine. And earlier I started her off with just half tablet, then went on increasing serially till she was comfortable with one tablet 3 times. It's very important for us to know that she continues this metformin tablet, because as we all know, now this PCOS has been named as PMOS because it is a polyendocrine metabolic ovarian syndrome. So, giving metformin to these patients is mandatory. The second tablet which I gave her was myoinositol and melatonin, which also is very useful. 1 BD, that's once, twice daily. Folic acid, we give them before 3 months at least starting the treatment of pregnancy and continue till delivery. This metformin also is the same. Sporlac ART was something which I introduced to her in this treatment, and that I gave her 1 tablet twice a day. Actually, it is a capsule. I think some noise I'm getting. Thyronome tablet, 25 milligrams, because when she came to me in the initial period, tested her for T3, T4, TSH, and the TSH was 3.9 MIU per ml. So that is the reason I started her along with 25 milligrams of Thyronome. Also gave her nutrient supplement or support, that is calcium and protein. Most important, more than all this, whatever we had given, was lifestyle management. So advice was given to her to gain muscle mass. So that is, exercises done against resistance and not just the aerobic exercises. As the patient, of course, because she presented with the thin lean PMOS type. Now, IVF stimulation protocol, we did a antagonist protocol. Here, in the initial 5 days, we used the recombinant FSH 225 IU, followed by 200 IU of HMG. I reduced it to 200 because this lady was very thin. And so we had given 11 days of stimulation with the gonadotropins. And then we started 0.25 cetrorelix for 6 days. We generally start from the 7th day onwards. Trigger was given in the form of injection uprolide, 3 milligrams subcutaneously, and trigger was given on day 11. OPU was done on day 13, that is 29/12/2025. Sperm wash comparison, pre-wash and post-wash. Volume was 2 ml pre-post-wash 0.5 ml. Concentration was 90 million per ml pre-wash, post-wash 60 million. 60% initially in the initial wash, and then it went up to 78%. Normal morphology in both cases. Now, this is one of the most beautiful slide that has been ever prepared, and I'm really fallen in love with this. Thanks to my embryologist for doing it and also making this slide for me. Dr. Nancy Sharma and Sanjay was also involved earlier, but now Dviti, really puts on the crown. So now we just imagine we were able to pick up around 50 number of total oocytes. We did a half century that day. And you won't believe that there are M240, M13, and GB7. And look at the embryo development timeline. Out of the 50 and 40 that M2, 40, all 40 fertilized. This is something incredible. That is 100% fertilization rate. And then this went on to being the day 3 embryos, 8 cell stage. So here 32 became the day 3 embryos. That's 80% day 3 cleavage rate. These 32 went on to develop 28 day 5, day 6 blastocysts. That means we have a blastocyst rate of 70% in this case in our laboratory. 3 cheers to my embryologist, Nancy. And then we also had 18 out of 10 good quality, average quality blastocyst. That means the best quality of blastocysts were also around 45%. This is also incredible. Ever heard of? Now, the embryo transfer protocol, I generally like the modified natural cycle wherever the patient has ovulation. So, gave her letrose 5 milligrams for 5 days. A recombinant HCG was given 6,500 trigger. And the monitoring parameters for the triggering was the follicle size has to be more than 16. In this case, it was 16.6 mm. And the endometrial thickness can be anywhere above 8 millimeters. What is most important in investigations is the serum progesterone, which should not be more than 1. And in this case, it was 0.2 MIU per ml. And estrogen, I just do it in all my cases. I want to do a study on this serum estradiol and MNC, so I keep on doing. LH has absolutely no value, but then as a routine, I got it done. Now, after giving the trigger, we start off after 36 hours with tablet dydrogesterone. We know we have to do the priming with the progesterone. So dydrogesterone, 10 milligrams TDS for 6 days. Vaginal progesterone, 400 milligrams, 1 BD, 6 days. Injection progesterone aqua, 50 milligrams subcutaneously once a day for 6 days. Then this is about the embryo transfer details, one of the most important step in our IVF labs. This is the embryo transfer cycle number 1. Embryos transferred were 2. We always ask the patient how many they want how many embryos they want to be transferred, because they are their embryos. Though I personally feel that it should be 1, but we listen to the patients, right? And the grade of embryos was 4AA. Catheter used to scoop catheter. Blood on the catheter, yes. Only on outer catheter there was, very little bit of blood stain seen. Transfer was very smooth. So when we did her beta HCG, it was 11,009 microliters per ml. And gestational sacs, we had 2 gestational sacs in this lady. Now, luteal support, again, as I told you, whatever we were giving, all that we continued. We also included tablet prednisolone 5 milligram early morning on the day of transfer, and then continued that till the result. So these are some of my books. And so thank you so much for a very patient listening. One another thing I have to tell you all regarding, can you hear me?
Yes, ma'am.
Yes, yes.
So regarding this case, I want to tell you all that after the twin sacs were seen, and as soon as the patient gets the fetal heartbeat, we again shift her back to the referring doctor. And after a few weeks, we had heard the news that one fetus did not survive, and then only one fetus has survived and continued to grow well. So this is the story of a lean thin PMOS whom we took her for IVF, and we gave her a pre-treatment and were very successful. Yeah, and I want to really thank Dr. Nisarg for keeping all the labs so well, for training everybody so well. And also Nancy, she's one of the best embryologists that I have known. And Dviti is also too good. She helped me a lot in preparing these slides. And of course, Sanjay was very nice, but unfortunately, he's gone to another place for his work. Thank you so much, all of you.
Thank you so much, ma'am. The session is open for question and answer round. If anybody have
Okay.
any sort of question regarding the case, you can definitely ask, madam.
Good evening, madam.
Yeah. Rushi, yeah.
Yes. In cases of PCOS or PMOS, after conception,
Yeah.
till what weeks you advise to continue metformin?
Yeah, that's an excellent question. I actually give the metformin up to till she delivers. I continue because, as we understand, it is they all are having this metabolic syndrome features. Insulin resistance is there even in the thin lean PCOS. So we should not, I think, inadvertently stop metformin. There's no harm in continuing the metformin.
Yes.
In same dose PDS or do we decrease the dose after some time?
No, same dose. I continue the same dose.
Okay, thank you
Only
so
if the
much.
patient is having any problem with the metformin, then we are not we can decrease the dose. But because metformin is such a molecule which the patients starts getting used to it, and then generally after that they won't have any problem. Initially, in some patients I have seen, I had to start even with a pediatric dose. Liquid metformin also, because they're not able to tolerate the metformin. Then slowly, gradually, 1 month, 2 months, they will take to, because we have to give them this. There is even other forms of insulin resistance tablets which can reduce our, pioglitazone and all, do not work well in our patients. Yeah.
Thank you so much.
Good evening, ma'am.
Good evening.
Very nice presentation. Ma'am Shraddha here.
Thank
My
you, Shraddha.
ma'am, my query was regarding the E2 levels and what is the optimum E2 level you expect, which is good, for in case of an MN, you're doing E2 for such
Correct.
patients.
Yeah, that's what when I was showing that slide also, in this case, the E2 was 165. And in case I would have taken it seriously and thought that, okay, let's cancel this cycle and all that, we would have lost all those 50, oocytes and all the 40 M2 and all the 40, embryos. So what I have found out in due course of my, uh, tenure is that E2 is not at all important because the blood levels of E2 do not come properly in our setups here. I have seen patients who used to come from Japan or some patients who used to, online consult with me. They always do a E2, and they had this value of 200 to 300, which the doctors there, they consider as normal. But here we do not get the values properly, and so best is to depend on our endometrial thickness and the vascularity. Put a color and then you will know how is the endometrium really, is it really healthy or not. Yeah.
Okay, ma'am.
Yeah.
Thank you. Thank you, ma'am.
Thank
Good
you.
evening, ma'am. Deepa
Yeah.
here. Yeah.
How are
Yeah.
you?
Yeah, fine. Thank you, ma'am. Ma'am, I had two questions. How many months of priming do you feel is adequate? Because we are often finding it difficult to give that priming when the patient comes with a mindset of getting an IVF done, be it a thin or an obese PCOS.
Yeah, so I'll tell you. Here in IVF, you are going to be a great artist, not only doing IVF, but in counseling. You have to counsel them that if you don't do this, we may not be successful, and all that large amount of money we are going to put in this case will be wasted. So counseling plays a very big role. You have to have patience, you have to have time and counsel them. I think most of them will agree. And now, Deepa, nowadays with the semaglutide and tirzepatide, life has become very easy, though it's expensive and only for the richer class of patients. But semaglutide is not very expensive. So you can, if there's so much in a hurry, we can do it in 3 months, right? We can reduce a large number of kilos in 3 months. But then I feel slow and steady with the conventional method of exercise and dieting, in more protein intake, that plays a good role. You
Yeah.
have to give them a pre-treatment. I have seen the pre-treatment Kamal in many of my patients. There's no, just because the patient is telling we cannot go on and doing. I think you can counsel. Deepa, I know you.
Ma'am, should we get done any like insulin resistance index values before we start in a thin PCOS to regarding the dose of metformin? Like, do we give it in a TDS dose because the BMI is less? So I just
Yeah. So I'll tell you, supposing a patient's BMI is low, you can give a little bit lower dose. Okay.
Hmm.
We do not have less than 50 or 45 kgs or something, or BMI. But this patient was 19.5. I had given her 500 TDS. After 1 month or so. Initial 1 month, I give, lesser dose, but after 1 month, they get
Yeah.
used to it. So you can give, that is the proper dose. But then if the patient is not able to tolerate, then even you can give, something is better than nothing, right? So you can even give them 250 milligrams twice a day, etc.
Yes,
Yeah.
ma'am. And
And once
secondly,
you
ma'am.
consult also, you can lower the dose if you want, because then most of the body will take care. So you
Yes.
can, lower the dose in case necessary.
And I saw that, ma'am, you give myoinositol separately from metformin because most of them say that the combination of metformin and myoinositol in one tablet is irrational. So it is better to give it separate, is what your experience says, ma'am.
Yeah, because what I give is not just myoinositol.
Hmm.
Actually, so many people have fought with me in our lectures and all that because they don't believe in myoinositol. But according
Yes.
to me, inositol is passed 5 times more in the PCO subjects than the normal people. So there's definitely a role of giving inositol. And inositol has a good role on the oocytes, on the embryos, etc. So inositol is good to give to them, and it does not do any harm. It is there already in our body. So it can be
Yes.
given as a supplement. So I give in combination. I give myoinositol plus melatonin. Melatonin I give because these patients have actually the problem is there in the brains. The PCOS patients, they do not, their rhythm is altered. That circadian rhythm.
Yes.
So
Yes.
first of all, when we do the lifestyle management, we have to tell them that in the night you go to sleep at the same time and a little early. They all sleep early morning, 4 o'clock, get up in the morning at afternoon, 12 o'clock. And all. You should talk to them, you'll know. So you have to tell them sleep at the max 10:30, not beyond that. Get up at 6:30. So once they start getting up early, they'll have ample of time to even do exercises, right? So
Yeah.
melatonin helps them to have good sleep. That is the thing. Yeah.
Yeah. Any take on berberine, ma'am?
Yeah, it's coming in a big way, but I have not yet given in my patients. Maybe we should start trying it. There is a buzz about berberine. Yeah.
Okay. Thank you, ma'am. It's very
One
heartwarming to very good results with PCOS. We don't
Yeah.
get it that often.
I mean, we get many follicles and but
Quality.
get, but the blastocysts, that was amazing.
Yeah.
Yeah, I think it's a teamwork. The referring doctor has so much faith, here effort, then we could do our best as clinicians, and then only clinicians we do it is of no use, no. I think in our Bhopal, I think everywhere it is there in Sneh, but I can only talk of Bhopal. We have such coordination, me and Rishi, we are very, very good friends and we discuss and do a lot of things. And then we have good embryologists, and even that Dviti is so good, she's our junior embryologist, but she's awesome. She made all this, some difficult things in my life, she made it easy by helping me do the slide presentation. And Nancy, I already have told so many times. More than that, I'll tell you, the staff are so good there. The OT staff, she's absolutely marvelous, Basanti. Every step is important, everybody is important. Yeah.
Thank you, ma'am.
Thank you so much.
And one thing I want to ask,
Yeah.
after a patient gets conceived, how long do
Yeah.
we continue with metformin for those who are PCOS?
Yeah. So I continue metformin till they deliver. That's what I have read in the literature. And there's no harm because after all, these patients, as I already told you, they do have a metabolic syndrome issues. So insulin resistance is always, supposing we stop in between. These are the patients who have PMOS patients consuming may go for gestational diabetes, which we do not want. So to prevent all those problems, it is mandatory that we continue metformin.
Okay. Thank you.
Thank you so much. Who was the
Ma'am,
last one who asked the question?
Ma'am, question.
Acha, question.
ma'am, one
Good
question
afternoon,
on
ma'am.
sporolec. Yes, sir.
Yeah.
Yeah, good afternoon, ma'am. Do you recommend any test or any bifurcation when we are planning to start metformin? So, do you recommend any investigation, or because so many people are starting in a haphazard dose at various center in various clinics? So, ma'am, do you suggest any dose and reports before that?
Maybe because it's most probably there won't be any issue wherever I have started, because from low, as I already told, low dose to a higher dose. But basic, all the investigations, and maybe I really do not know about this. Maybe liver function tests and all that could be mandatory.
Okay, ma'am.
Yeah.
Good evening, ma'am. This is Dr. Tejal from Baroda. I had one simple question.
Yes, Tejal.
So when you mentioned that for MNC we give the trigger, then after 36 hours we start the progesterone and 6 days of progesterone. So our transfer will be on the sixth day, the last dose of progesterone, or on the seventh day after the sixth dose of progesterone.
Actually, even till today, I sit and calculate. You have to take a pen and paper and sit and work on it.
Okay.
It should be 5 days complete. Actually, our staff in Sneh Bhopal, they also calculate. I think it's the fifth injection progesterone when we do the transfer. Rushi, you can tell now. That's right. Is Dr. Rushi there?
Actually, yes,
Ah,
yes, ma'am. In Bhopal, we do after fifth dose of progesterone, injectable progesterone.
correct.
That is
Okay.
approximately between 108 to 112 hours
120.
of starting
Yeah.
the progesterone.
I think I
We
saw,
do a bit earlier. In
yes,
Maninagar, we are doing a little earlier than Bhopal.
yeah, I understand because when the staff used to say that I was doing at 120 and Dr. Ushma was doing it very, very early and Dr. Rushi was doing in between me and Ushma. That story I heard. But now I'm getting nearer to Dr. Rushi's regime. I think it is really good. Yeah. 112, right? 112 hours.
108 to 112.
108 to
Correct,
100.
correct.
Yes.
Yeah, so the window, we have to understand the window of implantation is very wide in this case. We don't have to be so
Right.
worried. Yeah.
Okay. All right.
Mm.
Okay. Thank you, ma'am.
Yeah, thank you.
One thing, ma'am, I would like to ask is regarding Sporolac ART,
Yeah.
which patient to choose for giving free treatment with Sporolac ART?
Yeah, I will tell you. Actually, you can give any of these probiotics and prebiotics that you want. This Sporolac ART is a little bit expensive. There are inexpensive also which are available, but I am used to this Sporolac ART. This is given what I do in most of my cases of PMOS and endometriosis. I give just because there's dysbiosis. The bad bacteria are plenty here. Why? Because they're causing a lot of inflammation because of endometriosis. You all know also that PMOS is also an inflammatory condition. Wherever there's especially in PMOS, we have the gut dysbiosis, which goes descending into the genital tract, the vagina, etc. So if we give this, it will really